Okay then, Mark, welcome again to this Infocast. I think this is our third Infocast, Mark. We first met and started talking about vaccines, and particular vaccines in the context of PH, just at the rollout of the vaccine program. But Mark, just so people who might not know you, could you just introduce yourself and we'll take it from there?
So I'm Mark Toshner. I'm a pulmonary hypertension doctor down in Cambridge, where I'm also a lecturer and I work in research and in particular clinical trials. And I guess for the context, the main reason we've been talking is because I was involved as the local investigator in at least a couple of the clinical trials of vaccines.
Okay, so Mark, when
someone's whistling in the background. That's one of my colleagues.
That's fine. That's okay. This is live. This is real stuff. Okay. When we first started talking, we were in the first few days of the vaccine program being rolled out in the UK. On the 29th of March, which is the 29th of April, as of yesterday when we're recording this, we've nearly had 48 million vaccines administered in the UK. From your perspective, Mark, where are we at, and what are the challenges going forward?
So I think we're in a very good place actually now, and we weren't at the start of these infocasts. We were, I think, it would be fair to say, in a bad place. The vaccination program's been an unequivocal success. That and the combination of the rather dreadful lockdown that we've all just come out of have made a really dramatic impact on the prevalence and incidence of COVID. And so now we are actually in the best shape in Europe from being the absolute poor man at the bottom of the leagues. Currently our incidence is lowest in Europe.
Mark, can I just ask you to explain something? Because you say you use prevalence and incidence in your previous sort of comment. What does that actually mean in the context, so I can understand it, let alone anybody else?
Good question, Ian. So there are about 1,500 people still in hospital.
Okay.
And that's prevalent. So how much of the disease is about? But the incidence, so how many new people are getting COVID is very, very low. So we have, I think, looking at the latest maps, the lowest, or certainly the lowest 10% of incidence in Europe. So we've gone from the pariah state of Europe to being in really good shape going into the summer. And the great news is we've managed to vaccinate all our at-risk populations in very, very high proportions. So if you look at the graphs that are kind of commonly being distributed in news and in social media, we have a over 90 to 95% take up in the stratified populations who are at risk, and that includes age and also disease, and certainly that seems to be reflective of my pulmonary hypertension cohort. I don't know how your lot are getting.
So you know, when you say, Mark, about at risk, that's not is that at risk of suffering significant consequences rather than COVID itself?
That's right. Yeah. So at risk of becoming unwell with disease. So the good news, certainly locally, and I think this has been paralleled around the country, is that for the pulmonary hypertension patients, they are all vaccinated now, and that has gone pretty well and pretty safely, and so we're looking good for the summer.
Good. Now, clearly, you know, we're all aware of media and news items and concerns, and some of these are genuine. I want to try and address some of the questions and the challenges of vaccination and some of the concerns. Not quite sure where to take it, but if I could just lead on, say one of them that's really quite common is the risk that the media sometimes reports, whether it's true or not, of issues with clots and vaccinations. What's your insight into that?
Sure. So it's a difficult one, because the story has moved in the last month or two from being a question mark to being fairly convincing, and so I think we're in a position now where we can say that with particularly the adenoviral based vaccines, and that's predominantly AstraZeneca and the Janssen or Johnson & Johnson vaccine, there appears to be this rare side effect that's characterized by low platelets and by clotting in unusual places. And
what do platelets do, Mark? Do they cause the blood to clot, or?
So platelets are an integral part of how the blood clots. So the platelets are clumping together, and it appears to be rather unusually that the very with lightning speed scientists have been able to kind of clarify what they think the underlying reason for it is, and that's unusual antibodies being formed in rare cases that are basically causing the blood to clump together. So that's a short-term side effect. It's rare, but I think most of us are pretty convinced now that it's a real thing. Okay, so I know that some of the reports were sat in the fence, and some of the initial reports questioned it because data looked different in Germany and Norway and in the UK, and it's taken a while to kind of clarify what the picture is. But I personally am now pretty convinced by the data this does appear to be a real side effect, and it's happening at the moment. Our best guess is in the frequency of 1 in 50,000 to 1 in 100,000 people. So it's still rare. So it's a very uncommon side effect, but it's not a trivial matter, and it's not something I would downplay. It's real, and it's something that has to be taken into account as we assess both individual choices about having vaccines, but also from the perspective of what we do going forward, because it is likely we're going to need to continue vaccinating people, and there will be some decisions to be made coming up about how we do that and how we change our programs.
So if you were an individual, say a member of the public, a patient with PH, or a loved one, somebody, and you were trying to make the decision, how would you want to help somebody make the decision? You bear in mind it's a very rare event to feel comfortable, but I suppose this is something about risk and benefit.
Yeah, and it's actually something that most of our patients do intuitively all the time, although sometimes we, even as doctors, don't do it very well because we're not good at balancing and figuring out risk. Obvious examples of that are people have a disproportionate fear of flying compared to driving, but your annual risk of dying in a road traffic accident in the UK is somewhere in the region of 1 in 20,000. And in fact, your annual lifetime risk of dying in a road traffic accident in the UK is 1 in 250. Right. So it just gives some context. Yeah. We know that there are some things that we accept as risk in normal life and we don't even think about. There are other things that we perceive a risk, and although the risk is there and real, it's so small as to be, almost non-existent. Some people have compared the risk of a vaccine to the risk of being hit by lightning. Now, I don't think that's a useful comparison, because on the one hand, with a vaccine, you're actually actively going to do something that's causing risk, whereas, a lightning strike's a difficult thing to mitigate against unless you're going to stay indoors whenever it rains, and in the UK, that's quite a lot. Yeah. So I think, but it gives us this concept of how we think about risk and try to manage it on a daily basis. And so I am keen that people have a clear understanding of the data, so of the risks versus the benefits, and get to make their individual decisions. Mm-hmm. And I think we need to be, and hopefully all the way through the pandemic, I have highlighted individual choice. It's about you choosing something, and nobody should ever be forcing you, but choosing something with the best of information that you can at your fingertips. So one of the things, for example, if I can share my screen, is a comparison of the risk of COVID versus the risk of a vaccine or one of these vaccines. And that until now has been the really important comparison, because it was never a question of getting vaccinated versus not getting vaccinated. It was always a case of getting vaccinated versus the risk of COVID. So you don't mind if I just very quickly share a couple of slides? So this is where we were back in January. This is some really beautiful illustrative data from the Winton Centre down in Cambridge, showing in January in the UK what the risk of being hospitalised with COVID-19 was across different age groups. So our PH patients would have been a high risk group, even despite the fact most of them are relatively young. So these numbers would have been conservative estimates for them. But this is the general population. And as you can see, it's very, very clear the risk on the left-hand side of being hospitalised and having severe COVID across all age groups was much, much higher than the risk of having a problem with a vaccine. So in January, facing the question, should I get a vaccine? The answer was unequivocal. There was no, if you were being logical about it, if you were weighing up the risks versus the benefits for the whole population, it was very, very clear. This is closer to where we are now. So we are now back to September levels of incidence. And as you can see, for some members of the population, if we're simply thinking about the chance of you becoming unwell, then it's more complicated, because the two sides of the equation, particularly for younger people, are more balanced. Now, unwell isn't the only measure here.
Mm-hmm.
And so it's not quite as straightforward as just looking at one side of this graph versus the other, because there is the risk of complications, and we know that long COVID is significant and really affects people. So anywhere up to 20% of people who come out of hospital still aren't back to work after about 3 to 6 months, and somewhere in the region of 20 to 50% are still having significant symptoms. Another 10% of people post-hospital unfortunately die within the first 3 months of discharge, and another 20 to 30% are readmitted to hospital. So COVID has implications beyond just being hospitalized or your immediate mortality. And it also has the implications for those around you. So if you are worried about spreading COVID, particularly to vulnerable relatives who may or may not have been vaccinated themselves, then that comes into the individual's decision about what they do. The other thing is that this is comparing hospitalizations. So hospitalizations, about 30% of people that are hospitalized don't make it, but some people may say, but these clots are significant, and maybe hospitalization isn't the correct thing to compare it to. So if we look at intensive care admissions, and again, this is back in January at the peak, you still are very clearly, if you're being evidence-based and if you're being logical, unequivocally falling down on the side of having a vaccine back in January. But now things are maybe a wee bit more nuanced. Now, remember that risk and incidence isn't static. So this changes with time. If you go based on what's happening now, you're making a bet that for this next 6 months, the rates of COVID aren't going to go up again. And so it becomes more shades of grey.
Yeah. And
I think one of the other things to talk about is what's going to happen later in the year when we have available stocks of more than just two of the vaccines, and so that's something that you also need to consider. So I think most of how I feel about this hasn't changed. The general advice remains exactly the same, but I think there is a little bit more nuance in an individual's choice now, and it really should be up to that individual to be allowed to have a think and to weigh up the pros and the cons.
Is there any understanding, Mark, that mass vaccination like we've experienced in the UK actually reduces transmission? So rather than protecting myself as an individual, if I vaccinate myself, yeah, am I doing something for others?
So we've got a lot of accumulated evidence to be pretty positive about that now. So although none of the studies have looked directly, well, there is one study that's looked at households in an observational setting. So that's just, rather than prospectively setting up a trial and looking at it, they've tried to link families and friends. But we've got very clear population data now that the vaccines dramatically have impacted on transmission, as well as reducing the amount of actual infections in the people who are vaccinated. So I think we can be pretty confident now that vaccines work on all levels. They prevent severe disease, they prevent moderate and mild disease, and they prevent you transmitting to people round about you.
So does that say anything? And I know I'm asking an opinion here, Mark, but you looked at the graphs that you described, those slides that you showed there, in the younger population, that the chance of being hospitalised and being impacted is really small. Does that give some argument, do you think, though, while that's the case, if you do go down the route of being vaccinated, you actually protect others in society? Or am I trying to extrapolate something that's not there?
No, that's unequivocally there. So that is regardless of your ranking of your own individual risk, a vaccine reduces risk for people about you. And so it's a reason some people will choose. But then I think I am very keen that we don't try to make this a societal pressure, because people are making a positive decision to do something, and I don't think people should feel under pressure to do it. I think they should know what the benefits are and know what the risks are.
Okay. I mean, we'll go on to some of the sort of moving to the future, but just thinking of some of the questions that we've had from our, through our sort of social media type things. What about people who, the clinically vulnerable, people with PH, etc. Now they've been vaccinated and things. Is this the right time to start getting out and about, or what? Back to normal?
Yeah, I think we can be cautiously optimistic here, and all the way through the pandemic, I've tried to take a low risk approach. So even sometimes we don't know the answer to these things, and then it's about trying to figure out, okay, what's the balance of the risk here versus versus the potential benefits. And so I think actually generally what we're doing right now, this phased reintroduction of normal life, is the right approach. And it may be that we could go quicker, but is it worth the risk of us ending up back where we were in January? And so I think a couple of months of gradual reintroduction of normal life is the right way to do it. And even when we get back to normal life in the summer, I expect some of these measures will still stay in place. So I think people are going to be more cautious, and I suspect that includes our pulmonary hypertension group, who, speaking to them in the clinic and in the wards and on the telephone, they perceive the risk as high to them, and therefore have generally been pretty cautious and pretty sensible anyway. So things like face masks may continue in some fashion as part of your everyday, life when you're in places that are poorly ventilated, or if you've got, symptoms. And again, that's something that we're going to kind of feel our way through. But I expect us to get back to a normal of sort over the summer, and so people can be looking forward to that in the next kind of 6 to 8 weeks.
Now when we first started talking about vaccines, Mark, there was just a couple on the market, as it were, to talk about the marketplace, and now there seems almost like a choice. And bearing in mind some of the things you've talked about with risks and that I was thinking of, you mentioned AstraZeneca, there's the Pfizer one, Moderna, and some of the national policy from the government about who should access Moderna. What's your insights and thoughts on that?
So at the moment, they've restricted it to the under 30s, and that's based partly on some of the data I showed you, where the most equipoise, and by equipoise I mean balance of risk versus benefit, is in the 30 and below group, because they have a very low risk of serious illness with COVID. And they've based it on that criteria, but none of the rest of the criteria. So they're not taking into account things like long COVID or transmission to people around about them. And I think that's the right approach, actually. We might see that change a little bit as time goes on, and it partly will also depend on the stocks of vaccines available. And we know that actually the vaccine task force did a really good job in the UK of making sure that we weren't reliant on one vaccine only. And so in the winter, as we come into the winter, I think we're going to have more than one option. There's a moral dimension to this, because we have knocked out the park in the UK, and we've really done a great job of vaccinating the people who really needed it. But we're an outlier, and there are huge areas of the world where vaccines haven't really even started to take off yet. And so I think we need to be thinking beyond our small little patch and looking at places like Brazil and places like India, and starting to think of the supply of vaccines not as a national thing or a local thing, but as an international resource. And we need to think a wee bit more fairly and equitably about how we distribute vaccines around about the world. It's brilliant that in the UK we were bold and clear about the vaccines that we were going to commit to, and we got contracts in place, and we have good supplies. But on the one hand, we get those vaccines, and other places don't because of that. So having vaccinated most of our vulnerable population in the UK, I think we should be really looking abroad and saying, how can the vaccine supplies that we've managed to ring fence be best used do the most good, because there are places around the world where those figures that I showed you right now are very much still in play, and in some places even worse. So there are some difficult decisions to take, I think, as a population now, and people need to be engaging with that, because it's very easy for us to be sitting back now and be pleased with ourselves. But if you look around the world in the last week or two, we have had some of the highest incidences on record. You know, we're a year in and it's still peaking. You know, we've not hit peak. And unfortunately, if India goes the direction we all fear, it's going to get even worse. So I think there's a real risk of nationalism, in particular vaccine nationalism here, and it'd be good for us to, as a community in the UK, to engage with, starting to think about how we might be able to help others.
I mean, I think one of the things is really interesting conversation there, Mark, because one of the things that the pandemic, by definition, has done is that we live in a really small world, and what happens across Europe or what happens in India has an impact on ourselves as well. By definition, we're in this. We have a pandemic because we've got a small world, so we have to address that in those sorts of ways. Thinking about the sort of the immediate future, I know I think I'm right. This week, the government announced, not exclusive, not with great clarity, but about booster doses later in the winter, and the purchase of, I think, 60 million doses of another vaccine, and that. Do you think that's going to be the way forward in the UK, even allowing for the conversation you just sort of gone through there?
Yeah, well, I expect that for the foreseeable future, the COVID vaccines are here to stay. So I expect us to all end up with a booster, or for at least portions of the population to end up with a booster every year. And so the question is going to be, do we need boosters that cover against new and emerging variants, or are the general vaccines that are available going to be able to protect us? And we don't know the answers to that right now. So I am expecting us all to be offered additional doses later in the year. And at that point, as a kind of society, we probably need to look around and say, is this the best use of the vaccines, and what have supplies done elsewhere? Mm-hmm. And in particular, the COVAX WHO program, which is trying to sort of ensure global equity, is something that we have in fact invested in, and I think we should be encouraging our government to invest in it further. So I think it will become part of normal life, and whether it's for the whole population or whether it's for part of the population, I think is still an open question. But the good news is the success of the program has been quite astonishing, and we know, because the data is very clear, that thousands of lives have been saved by the vaccines that have been deployed now.
Yeah. Do you think what are the questions we keep getting in the PH office, and I know in the general media going forward as well, because we've gone almost like a demographic of age groups which down with the vaccine. Do you think we'll ever get to the point of where the discussions are around the younger people, like children, being vaccinated? And
yeah, so there are some countries that are offering children the Pfizer vaccine already. I think it's a much more wrought area. It's a much more complicated area, because the proportion of children who get unwell is very low. So I think if we're going to vaccinate the children, we have to be absolutely, completely convinced that the safety is good enough that your risk benefit remains in clear daylight. And for some of the vaccines right now, I don't think that's the case. So I expect that it's only going to be once we've really established beyond a shadow of a doubt that the vaccines that are most safe are still most safe for children, before we start to go down that route. And it will eventually happen, assuming that safety is demonstrated. But I'm not in a particular rush to go down that route just quite yet.
One thought that's, I'm sorry, because I'm going to jump back to sort of clots and stuff like that, because I've just been reminding myself in the context of pulmonary hypertension, thinking of people with CTEPH, so people who have chronic pulmonary hypertension, and clots and vaccines. that creates a more, can you talk to that a little bit?
I can, yeah. So I think we don't have any evidence that patients with previous clots or patients with CTEPH are at more risk of this. So the mechanism behind it, or essentially what is happening in these patients, isn't like a normal clot. It appears to be that the body is generating an antibody that by coincidence recognizes a particular protein involved in the clotting factors in and around platelets. It's a thing called anti-PF4, and that's not a classical cause of clots in our population of patients, and we haven't seen any patients with CTEPH who have had this complication. So we don't think it's a particular risk factor, and we don't think that this population or our population of patients with chronic thromboembolic pulmonary hypertension are at particular risk. They've all been vaccinated as well at this point, and we haven't had any reports. Yeah. So I think we can at least be confident that the rare risk that we're talking about with both the J&J and the AstraZeneca vaccines does not appear to be any more relevant to our patients than to the rest of the population. But because they're so rare, it can sometimes be difficult to pick up because the numbers we're talking about are in the dozens, or I think a couple of hundred now out of the tens of millions. I think there's something like 300 and odd million vaccines that have been, for AstraZeneca at least, doses that have been given internationally, and we're still talking about a frequency of in the low hundreds. So being able to tell patterns with those low numbers is tough, but at present those patterns haven't emerged.
Just moving back to the vaccines and things like that, and to try and conclude as well, one of the emerging things and continued debate in the media are this issues, and you mentioned it earlier about variants, and what do you think the challenges of those are, because that gives concern to people? Yeah,
and it's difficult sometimes to cut through all of that, isn't it? You know, we get almost a daily barrage of both positive and negative news, and the negative often outweighs the positive. I think where we are right now is that the news is generally, if you can dial down some of the hysteria, so far we are yet to demonstrate serious vaccine escape from the variants. So the SARS-CoV-2 virus is not a very quick mutator, but the reason that we're seeing mutations arrive is just because there's so much of it about.
Right.
So it is mutating. It's mutating at a relatively slow rate, but because there are so many people with it, the opportunities for it to mutate are high.
Can I just stop now, because what do we mean when we say it's mutated? What does that? It's grown 2 heads instead of 1, or what does that mean?
So a bit like us, it's got a genome. It's got a whole set of genome of gene codes, and just like us, they change from generation to generation. That's part of kind of Darwinian natural selection. Viruses that are very effective often do this rapidly, so they can respond to threats, because individual gene mutations that confer an advantage can very quickly, you know, take a hold and multiply. And so we do that. You know, humans do that. You know, we do it at a much slower cycle, but examples of that are relatively abundant. There's a really good set of examples related actually to pulmonary hypertension, where one of the quickest known positive adaptations in a population relates to resistance to high altitude pulmonary hypertension in places like Tibet and the Andes, and that's happened over a 10,000 to 5,000 year time frame. So, you know, a much longer time frame, but it's happened because individuals go to an area of high altitude, those that have particular genes that help protect against pulmonary hypertension do better, and that those genes are selected for. So viruses do the same thing. They are constantly evolving to try to make sure that they have as good a competitive advantage as they can. At present, we have a lot of variants of both interest and concern, and they're slightly different terms, but they basically mean the same thing, just virus variants that we're worried about. And they're being observed, and we're yet to see real world evidence that the vaccines don't work against them. There may be evidence that the vaccines are slightly less effective against some of them. And we don't know what we don't know. So we don't know if a variant's going to emerge in the next 6 months that will, that will seriously be compromised from the perspective of the vaccines. But at present, we don't have that situation. We've got a situation, I guess, specifically in the UK, where all of the variants that have been dominant are responding well to the vaccine, as demonstrated by the very low levels during the vaccination programme and the lockdown. And we know that the platform technologies that for these new vaccines are actually really adaptive. And in fact, already studies are being run where they've essentially just plugged in the new genetic code into their existing vaccine, and they're rerunning the study to update the vaccines so they cover these new variants. So actually, I would say that we're in a pretty positive position, much more positive than we could have hoped for, 6 months ago. But that doesn't mean we let our guard down and we assume this is all finished. It just means that I would be positive, not negative, about the future, and we just need to keep an eye on it and be sensible.
So just in conclusion, Mark, is your opportunity to think about the next 6 months and things like this, that because we do respect what you think. Your wife doesn't listen to you because she knows you really well. So the next time we do an Intercast, we might do it with her rather than you.
That would be absolutely hilarious. It would be hilarious. Yeah. Although I think it would probably completely ruin my credibility. Yeah. So let's
that'll go viral, Mark. Yeah. Yeah. The next 6 months then, Mark, either in the context of the vaccine, the virus, the pandemic, in pulmonary hypertension, but generally, overall, because, we're talking to a general audience. What are your thoughts for the next 6 months?
Okay. So, the first thing is to caveat heavily. I think my favorite quote in this is never make predictions, especially about the future. However, having said that, so having given myself that get out of jail free card, the next few months, I don't think we're going to see any disease. And I think we're going to get back to normal. I think the major challenge is now going to be trying to recover all of those missed opportunities for safeguarding our population, the patients who we know have struggled through this pandemic. So I think we've got a bunch of work to do to catch up and try to get everybody well again. A proportion of patients have become unwell because of the pandemic, because of all the restrictions and how we're able to look after people. I think one positive thing, however, that's come out of this is that the way that the pandemic has blown up our model of care and introduced completely novel things that might have taken another decade to come in. So for some patients, being followed up when you're stable by a telephone call or by a Skype interview, and having implanted technology or being able to be followed up using apps and phones and watches, these are all things that are now rapidly transitioning into actual practice. And you guys know, because some of this you've been pioneering in Sheffield. And these are all positive things because they're very patient-centred. So I think there's a real opportunity for us to reshape care around the patient and make sure it isn't centred around the clinician. We run medical services, for better or worse, at our convenience, not at the patient's convenience. And I think there's a real opportunity here to rebalance that a little bit. So that's great news. If we can get back on an even keel and make sure everybody that needs to be seen and have tests and have therapy changed if they need it, that's the focus for the next 6 months for us. Later in the year, we may have another wave of this. It will not be as bad as the last one, but most of the modelling is suggesting there will be another wave in the winter. And if there isn't a wave of this, it's likely there will be a resurgence of flu or of community-acquired pneumonia. So we will have a bit of a bumpy ride. It's not going to be as bad, I think, as the start of the year was. And we are all now much more matured, and we understand the virus much better, and we understand what needs to be done. So hopefully, even if that does happen, we'll cope as a community better, and we'll all be able to kind of pull in the same direction. I think that was one of the things that really amazed me actually in January, was that having gone through this horrible year and with quite a lot of potential societal strife out there, we all did just pull together and we did this awful lockdown together. It was so much worse than the first one, but we did it, and we did it actually with relatively little disharmony, I felt, and so I think we can be quite proud of ourselves for that. And I expect that the next time, if we have to do something more limited, we'll all be prepared better, and we'll be able to do it and minimise the impact on our lives, and not have to have months and months out like we did this year.
I mean, I'd echo what you said there, Mark, about certainly January, February. For me, they were the longest months I've ever experienced. I think there were 72 days in each month, and it just seemed to go on. But what can we learn from the pandemic? And this might, I don't say this sort of ashamedly. I think if we could only learn to be as gentle with each other as we have been going forward, and look out for each other better. And I mean that in every aspect of our lives, that we got through what has been a horrible period of time by listening and being kinder to each other, and that needs to be the way forward.
Oh, I completely agree. I think the thing I'm going to take, well, I mean, lots of things I'm going to take from the last year, and most of them not positive, but the one, really thing that I guess above all is how much we need each other, and we are social animals, and so that's been for me the hardest thing. Is I've seen my family once in a year and a half, and I've got vulnerable members of my family around the country who have I've had to do Skype with or Zoom calls with every day, and they're missing seeing their grandkids growing up, and so it's really sharpened my appreciation, I guess, like everybody else. I'm no different, for just the simple interaction with friends and family. And so hopefully at the end of all of this, we don't forget that. We can really take that for granted quite easily, but hopefully after this year, it will be harder to do that in the future.
Hopefully. Right, Mark. Well, thanks again for your time. I know you're sort of very busy, and we'll be speaking again. I will be in touch about an Infocast with your wife as well. Just we should get home. I'm
going to creatively make sure that doesn't happen.
We'll ask people to send in questions for Mark's wife. Yeah. Okay, then, Mark.
She's a gardener, so they can be gardening questions only, and we could have a wee break from the depressing chat about COVID.
Yeah. Good. Okay, then, Mark. Cheers. Thank you.